Good day to you. It's really nice to be here today. My name is Steve Forbush. I'm the owner and proprietor of Orthopedic Manual Therapy Instruction. You can find us on the web at orthomti.com, and we have a Facebook page also with the same name. We're talking about patient case scenarios, and today we're going to talk a little bit about a particular patient case scenario that happened in the last couple, 3 weeks for me. This patient started having plantar fasciitis and was referred to us with plantar fasciitis. And the plantar fasciitis started in November, early November. So now the patient has continued to have that problem through the entire month of November, December, January, February, and we saw him in March. During that time, he had seen a family practice physician who did a workup on him and did some x-rays, found nothing, and went to an orthopedic surgeon who also did an MRI and an ultrasound, found nothing on either one of those imagings, and then did an injection in the foot using a cane drug and anti-inflammatory dexamethasone without much effect. Had about a 1-day relief of pain and then sort of came back again. He's been unable to run. He is a triathlete. In his triathlete, he can still swim, he can still bike, but he's had this continuous irritation that's not allowed him to go back into any kind of events at this time. Now, on history, this is a 46-year-old male, very good condition, not overweight. I've watched him run, swim, and bike on video, and I can't say he's a beautiful swimmer, and I can't say he's a beautiful biker, and I can't say he's a beautiful runner, but he is effective at doing that. And what we did find in the history is that he had a event that he participated in the third week in October, and it was a half Ironman. Now, half Ironman is pretty aggressive. It was his penultimate event for him. He doesn't want to run a full Ironman. He doesn't want to do a full Ironman, but he did want to do this half Ironman to show that he could do it. And this half Ironman consists of, and you guys let me know if I get this wrong. This is off the top of my head, but I believe it's 13.1 miles running, it's 50 miles biking, and it's a half-mile swim. If I'm wrong, feel free to correct me. I have no problem. You can reach me at steve@orthomti.com, and you can give me a hard time. But regardless, it was a pretty demanding event. It took him a long time to complete. He is not fast, but he was very proud of the fact that he completed this. So let's keep that in mind as we realize that his pain started about 1 to 2 weeks after this event. Okay, so we see him in March, and we're doing a workup on him, and we're going to try to do an examination. So first things, what are you looking for? What kind of things are you thinking about up front? What kind of things do you think might be going on with this patient? That's what I like doing about patient case scenarios is I love listening to case scenarios. They give me lots of information. I like thinking about and learning how people think about cases and how they think about what's going on with people and how they make their decision-making process. And that's why we do this on this site and discussions. I'd love to do a little bit more of this where we're actually talking about your case scenarios, but right now we're just going to go through this and see what we've done. Now, he has seen another physical therapist prior to seeing me, and that person did some stretching and some activity of the foot and did some golf balls in the bottom of the foot and stuff to try to get him to feel better. Didn't really make much effect. So he's seeing me now, and again, this is early March when we saw him. So let's go through our examination. He came in, we checked him out for standing eval, and his standing examination. We did forward flexion, extension, side bending, some quadrant testing, all which came up negative for his lumbar spine. We checked his lower extremity. In standing, he was balanced at the pelvis. He was even throughout his legs all the way down. He has slight pronation in both feet, nothing really significant. And we watched him walk, and he had no limp. Okay, we didn't watch him run during the session. We did a couple extra examination tests. I do one that I sort of made up for myself, where I have them stand on one leg, and I watch the foot and what happens to the foot when they're standing on one leg. So typically, when someone stands on one leg, you're going to see if this is the arch side and this is the lateral side of the foot, you're going to see that the foot's going to sort of move back and forth as they're standing on that one foot, going supination, pronation, supination, pronation, supination, pronation, as a normal foot would respond. As he stood on his right foot, non-painful foot, he had a really good movement between pronation, supination, pronation, supination. On the left foot that it was painful, he stayed more toward pronation and had a hard time pulling out of pronation with stance. So we could sit there and say, well, gosh, the problem is that he has a pronating foot and therefore he has pain with pronation because he has a super pronating foot, and that's what we're going to do. We're going to put orthotic in and he'll be better. Now, he's tried orthotics. Hasn't helped him dramatically, helped him a little bit. Okay? So we did other things with him. So some of the things I do while they're standing is I have them do heel walking. So it's walking with dorsiflexed feet, heel, 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 and toe walking, as you guys probably have done before, just to test some of the function of the lower extremities. When he heel walked, he did about 6 to 7 heel walking on the left foot, and then his foot started to not be able to lift. Right foot continued to be able to lift. Toe walking, same thing. Did 6 to 7 steps, and then about the 7th step, his heel started to drop, and he was not able to keep it as high off the ground. So that's kind of a concern. We need to look at that a little closer, I think, as we go through the rest of the eval. As I said, the rest of the lower extremity, I really couldn't see anything that was really significantly different between the two, and that pretty much concluded what I had planned for his standing exam. If you have other things you do in standing exam, just think about what you might want to look at when he was doing standing and what kind of things you wanted to examine while he was there. So next thing I do is I put him in sitting and I check his sitting exam. And in that particular examination, the first thing I did was I checked his back, didn't have increased tone, didn't sit in an abnormal position, had a level pelvis sitting, checked his hips out. He had hip flexion without much irritation passively. Hip internal external rotation was even on both sides. He had no problems with his knee extension flexion at all. And ankle dorsiflexion, plantar flexion was normal. So then what we did is we did resistive and dermatome testing. So dermatome testing, no numbness, no abnormality anywhere in lower extremity. It's great. I love that. That gives me a lot less to concern myself with. We did muscle testing, and again, hip flexor strong, hip abduction strong, adduction strong, knee extension strong, both sides, knee flexion strong, both sides. So that we got into the foot and ankle, and his dorsiflexion was weaker on the left. Well, it's hard for me to test plantar flexion in sitting. Obviously, you can't resist plantar flexion to the extent you want to. So what I do instead is in my examination, the way I teach quadrant testing. I want to test each individual muscle. And so I can't test all the muscles, but I can test a lot of them. And so what we do is we do dorsiflexion inversion and resist that, dorsiflexion eversion and resist that, plantar flexion inversion, plantar flexion eversion. Okay. As I tested those, each tested different muscle. He was weak on the left in all 4 quadrants. So let's think what that means. A dorsiflexion inversion is his anterior tib. Dorsiflexion eversion is his toe extensors and his tertius. Plantar flexion inversion is his posterior tib. And plantar flexion eversion are his fibularis muscles, brevis and longus. Okay, so he's weak in all those muscles. I checked his great toe. Great toe dorsiflexion was weak, and plantar flexion was weak. That was interesting. Okay, so flexion and extension were both weak. His common toes extension was weak, flexion was weak, left side only. So that's pretty global, right? So we have weakness all through the lower extremity below the knee. Anything around the ankle and foot was weak. That was a concern to me. So We further looked at his ability to have mass in both extremities. I noticed as I felt through the calves that he had much softer calf on the left side than he did on the right side. And it didn't seem as full. So I did measurements, and he was actually an inch less in calf size on the left than he was on the right. That's pretty dramatic. That was kind of a concern too. So now we're thinking, okay, what could possibly create weakness of most of the foot and ankle and a decreased calf size on the left side? And my conclusion on that is it has to be something that's central. It can't be just a peripheral nerve because we're talking several nerves here. And it's common to the L5 root, or maybe you might want to say L5S1, but we have some root possible irritation. So that makes me want to do more examination of the lumbar spine. So what we did then is we took him from the sitting position. We checked all the strength. Everything was good, internal, external rotation, like I said, and the hips. So we laid him prone, and we did a PA testing of the lumbar spine. And you know that the research shows that PA testing just tells us which segment's involved. And when we did that, he had no tenderness at L5, 4, 3, 2, 1. Nothing bothered him. He had no problem over his sacrum and sacral springing. He had no irritation in any of the neural channels. So if you checked the sciatic nerve, he had no irritation in the sciatic nerve. If you checked his femoral nerve, had no problem with the femoral nerve. And he had no problem in the nerve channels, even lower in the extremity. So there's nothing I'm finding at all. His neural tension signs were minimally irritated both sides doing slump test. Not really anything that was dramatic on either side. So now we're really confused. So we have something that shows a global weakness of lower extremity. He does not have any kind of neuropathies that we know of, no history of anything in that source. And we're finding weakness and decreased mass in the left lower extremity. So now you have to think with me. I'm going to do a pregnant pause here. Let's just think, okay, what happened? What is happening? Is there anything going on that you are concerned with? Obviously, we don't have both lower extremities involved. We're not going to talk about a disease state. That's not something we're concerned about. Is there a neuropathy? Well, there's a nerve that at some time didn't function well, but we're not finding anything that says disc injury, anything else. I did find that the patient has a previous history of a disc injury in the lumbar spine, but had no back pain, no problem at this time at all, and he doesn't have any irritation at all in any of the segments of the lumbar spine. We're not really thinking that's going on. To further examine his lumbar spine, I did a sideline passive mobility test of each segment, and I found nothing that was really tight, nothing that was hypermobile using that testing. You may not use that testing. A lot of people don't. I do it just because it gives you more information, but it didn't give me any information this time. Nothing there. Okay? So, gosh, this gets really confusing. So what are we going to do? Well, my theory, and you always have to come up with a theory, right? You decide something's going on, you do something about it. So my theory is that when he did his half Ironman, he really irritated something in his back. Hypo, nerve root, something really bothered him. And he had enough irritation in the nerve that it didn't function at its full functional level. Decreased circulation, nerve irritation of some type, and he had resultant problems where he had functional loss. Okay, so over 2 weeks after that, he was probably not functioning as well as musculature. He was still trying to train, and he wasn't doing well training, right? He was not functioning as well as he wanted to. And when that happens, then you start having pain. So I don't know of anybody that looked through all that area and checked his lumbar spine or checked his hip or checked his nerve or at the time after the injury until, I mean, I have no idea what the other therapist looked at that was working with him. So all I have is the data that I have that says he has decreased strength, a lot of musculature in the lower extremity, decrease in mass in the lower extremity, no neural irritation that I can find. So My treatment for him, you decide what your treatment would be. My treatment was I want to increase the strength of everything in the lower extremity on that side. Now, you can choose to do that any way you want to. I have a tendency to really be impressed with the results found with blood flow restriction, medically applied for these type of conditions and post-surgical conditions, in that I find a mass effect that's faster. I find a strength effect that's faster. So I decided to do a blood flow restriction strengthening program for this patient. And worked on as much as I could in lower extremity. So as you know, blood flow restriction, I did 5 different exercises in the sequence that you're supposed to do with blood flow restrictions. I put them under the cuff. I had a 30 rep, 30-second rest, 15 rep, 30-second rest, 15, 30-second rest, 15, compressed the cuff for a period of 2 minutes, and then did that 5 different exercises. And he did things that involved dorsiflexion, inversion, dorsiflexion, eversion, plantar flexion. We won't go through all the exercises, but we made him work that calf as much as we could during that period of time, 5 different exercises. And then he's continuing that. So he continued that 2 to 3 times a week over 2 weeks. And so that's all we've had to monitor so far. It's only been 2 weeks since I first saw him. But interesting enough, his pain has decreased by 80%. And his one leg stance is now starting to move pronation, supination, pronation, supination. He's able to do more than 7 heel rise, heel stepping, and more than 7 of toe rising. So he's improved in all his strength throughout the area. We haven't remeasured his calf yet, but we probably would see more in that too. So we're feeling positive about the fact that he's going to have a good response to this, and it seemed like that. Now, again, you think about what you would have come up with, what you would have done, why you would have done it. I don't think there's one answer to any one of these conditions, but I just want you to think about it and what you would do. Okay. Thanks for going through this case with me. Love to hear some of your cases if you want to present them to me. So again, we'll try to make it so we have an open forum on discussing cases in the future. Just haven't set that up yet, but we'll do something with that in the future. You can visit my website at orthomti.com. You can go to my Facebook page at orthomti, and I have an Instagram account too. You'll see all that if you go to the other sites. Okay. I appreciate your time today. Thanks for being with us, and keep working hard with those patients.